In December, the ASGE published a guideline for the management of antithrombotic agents in patients undergoing endoscopy. There were previous guidelines dealing with these agents that were published in 2002 and 2005. How does the new guideline differ from the previous ones?
Well, the new guideline combines the two previous guidelines. In 2002 and 2005, the agents that were covered in those two documents were different. Like one of them covered warfarin and the other one covered aspirin, or vice versa. And so the new guideline actually takes those two and combines it into one single document, which should be easier for our members to access and use. The second thing that's different is that we have updated all the procedural risks. This is especially important because new techniques have been developed further or come along since the last guideline. Examples of this are things like the balloon-assisted endoscopy. That wasn't even in existence when the earlier guidelines, or it was in its infancy. And also things like cisgastrostomy that are used more commonly now. The second thing that it did was that it updated condition risks. So things like acute coronary syndrome and percutaneous coronary intervention, that's being done more and more, and so the guideline deals with those specific patient populations in greater detail. And then finally, there were publications that came out between the publication of those previous guidelines and our new guideline that compelled us to change the guideline and update it.
That last point sounds very important. Can you give us some examples of publications which have come out in the last 5 to 7 years, which have resulted in changes to the guidelines?
Sure. There's actually been a growing body of literature on the safety of polypectomy in patients on active aspirin therapy. An example of this was a publication by Sani and colleagues that was published in 2008 and looked at delayed severe bleeding post-polypectomy in patients on aspirin, and it was a case-control study. And they found that patients on aspirin were no more likely, they didn't have a higher risk to have bleeding after their polypectomy than patients who weren't. Another important study was one by Garcia and colleagues that was published in 2008, and that study looked at interrupting warfarin therapy in patients and whether those patients would have an increased risk for a thromboembolic event. Now that study was patients that had a low thromboembolic risk to begin with, like isolated atrial fibrillation, but what the study found was that those patients had a very low risk, less than 1%, if their warfarin was interrupted for 5 days, 5 to 7 days. And then the third thing that we thought was important was not actually a study publication, it was actually a guideline. So lots of societies impact our own society. An example of this is the AHA guideline, the American Heart Association, that was published in 2008, and it dealt specifically with patients that had had recently placed drug-eluting stents. Now that society made that guideline publication because there was overwhelming data that if those patients had their clopidogrel or aspirin or both interrupted in the peri-placement period, they had a really high risk for having stent occlusion. And so our new guideline takes that into account and reflects back the same sort of recommendations not to interrupt those drugs.
And where do there remain gaps in our knowledge about the management of antithrombotic agents before, after, and during endoscopic procedures?
That's a good question, and writing the guideline really brings to light the areas where there are gaps in our knowledge. One big area is in all of the non-aspirin antiplatelet agents. So there's really a paucity of data about the safety of endoscopy and endoscopic procedures in patients on things like clopidogrel and ticagrelor. Another area is regarding the management of warfarin. So really we don't know when to restart warfarin, for instance, after we do a procedure. Say you do a polypectomy, if you restart that patient's warfarin that evening, the next day, a week later, when is it safe to do that? Another area with respect to warfarin where there's a gap is hemostasis in patients that are still taking their warfarin. So you might have a patient that comes for a colonoscopy, screening colonoscopy, and they're still taking their warfarin. If you find a polyp, what options do you have? Well, one of the areas that's been investigated is using mechanical hemostatic devices like clips. And so we need to know more about how effective that is. And right now there's no randomized data. There's some non-randomized data. And then the final area where there's still a pretty significant gap is in patients that have supertherapeutic INRs. So right now, when we get called in the middle of the night for endoscopy and patients have high INRs, a lot of us are giving patients FFP to get the INR to a certain level, but there's really no prospective data about what level is safe. We know that it's probably safe as high as 4 or maybe even higher.
And one final question, are there any take-home points that you would like our members to get from these new guidelines?
Yes, I'd like to leave our members with 3 different important points from the guideline. Of course, the complete guideline has more than 3 recommendations, but these are 3 that are pretty important. What members will notice when they look at the new algorithms as they're published in the guideline is that almost all of them point toward continuing most agents for most endoscopic procedures. Specifically, the guideline states that it's safe to continue aspirin and non-steroidal anti-inflammatories for any sort of endoscopic procedure. There's going to be exceptions to that. If you have a patient that's taking Motrin or Advil for joint pain, and that patient you know you're going to do a high-risk procedure in, then it's probably safe and reasonable to stop that medication before the patient comes in. The second point I would like people to remember is that regarding patients that have acute coronary syndrome or recently placed drug-eluting stents, and that's that minimum period really be respected, especially if it's an elective procedure. So that's going to mean, delaying the procedure until the patient's had that minimum therapy, if at all possible. And when we do those patients after that minimum period, what we're recommending is that the patients have their clopidogrel or ticlopidine held and their aspirin continued. And that's really because there's more data about the safety of aspirin. And then the third point is really a corollary of that second one, and it actually has to do with this dual antiplatelet therapy. If it's a patient that's taking those medications together for another indication other than the acute coronary syndrome or the drug-eluting stent patient, so let's say it's a patient that had a stroke while on aspirin and is now taking clopidogrel, we're recommending that those patients have the non-aspirin antiplatelets like ticlopidine and clopidogrel held, but the aspirin continued or even added if the patient's only on one agent, and then restart them later afterward.